Thank you so much for that introduction, Dr. Steininger. Welcome, everyone. I am very excited to talk about today's topic, and I hope you brought your seatbelts because we're in for a long ride and a very fun discussion. So today I present to you the considerations in pediatric anesthesia for upper respiratory illnesses and PRAE. So let's dive in. Well, I wanted to dive in. There we go. So I have no disclosures today. This is purely a journal presentation. So our agenda for today is to define PRAE. What does PRAE mean? What is the importance to our culture and society? What does it mean for perioperative management? What does it mean for how we proceed to surgery? Do we proceed to surgery? How did this idea of PRAE and upper respiratory infections come about? What's the history behind it? And then we'll go into the key literature and the current practices of today. So let's begin with a simple definition. What is PRAE? PRAE stands for perioperative respiratory adverse events, and it includes a whole slew of things: laryngospasm, bronchospasm, apnea, hypoxemia, notably with a saturation less than 95%, prolonged need for oxygen, pretty much anything that includes anesthesia's favorite word, which is airway. Anything that can involve the airway and make a complication during the perioperative setting is what we're really looking at here. During my literature research, one of the most interesting things that I found is that there was no standardized definition of what particular journal included for perioperative respiratory adverse events. Of note, surgeons and anesthesiologists alike have dove into this concept, and it's interesting that the anesthesia world has very specific measurements for what they consider a laryngospasm or what they consider hypoxemia, versus the surgery world doesn't necessarily have those same limitations. So just to point that out before we head along this journey together. So why do we care? What's the importance of PRAE? So if you've ever been into an OR with a child, you pretty much know that a respiratory adverse event are pretty common in pediatric anesthesia. And that's largely why a lot of people are scared of pediatric anesthesia. When they see one of these things happen, it freaks them out, they panic, and they run for the door. And hopefully the person that's running out the door is not the anesthesiologist, but they do carry a high risk of mortality and morbidity. 3/4 of critical incidents and 1/3 of perioperative cardiac arrests are related to respiratory events. Of note, I kind of skipped over it on the last slide. I bolded it and we'll come back to it, but it's the idea of laryngospasm. In this 1/3 perioperative cardiac arrest, most of these cardiac arrests are due to laryngospasm. We'll dive into that more later. So the other importance is, since we know this high mortality and morbidity, it really is key to hone in on it so we can guide clinical discussion, target our anesthesia care specifically for these type of patients, and hopefully as an end result have better outcomes for the patient. And then this is a little opinion of mine, which is why it's blue and bolded, but I believe kids are the best and everyone should care about kids. And usually people do when it's a significant importance in the operating room. So a little bit of history on PRAE and upper respiratory concerns. So inquiries really began in the 1970s. People started to see an association of coughing and sneezing and a bunch of runny nose and congestion, which, if you've ever met a kid, is pretty common, especially when they started their daycare years. But nothing really solidified until about the 1990s, when this association got really reignited. And the first studies, the first two real mainstream data that we have are Tate and Cohen. And Tate really discovered the prevalence of these perioperative respiratory adverse events. And they noted that in asymptomatic patients, so kids with no cough, really no congestion, but that had symptoms of upper respiratory infection and 2 weeks prior to their operation, would have more respiratory complications. And then a few years later, Cohen and, and his cohort noticed that the morbidity and mortality with and without upper respiratory infections were 2 to 7 more times more likely to have PRAE. And with and without is whether or not they had symptoms at the time of surgery. And then this is what gets bolded and highlighted in this literature and why is still being on a topic of discussion today, is that the risk for perioperative adverse events increased 11 times if the patient required an intubation. Now you might be thinking, doesn't all anesthesia require intubation? And that's actually a great question, because in adult anesthetic considerations, no, but for the general population of most pediatric cases, they require general anesthesia, which requires intubation. So with that 1990s research, there began questioning. So how safe is anesthesia for this cohort of kids that are, sick and running around? And that really resulted into blank cancellations. We're not going to do this elective surgery. We're not going to do this semi surgery. We're going to delay your surgery. But since the pandemic time, mandatory viral testing during the pandemic opened up another avenue for further research. We had to screen a bunch of people, not only for COVID, but for other respiratory viral illnesses as well. And that has opened up a lot of data in the past couple years. So it remains an important topic of discussion, mostly because these practices for how to manage and what the anesthetic plan is really varies from institution to institution. So how do we go about thinking of stratification for risk? So this is where we dive into the preoperative assessment tool. So I apologize if it's a little small, but I wanted to walk through this table. This table comes from a review article that was published last year, actually 2022. And it's pretty much the guideline that pediatric anesthesiologists use. And the most commonly used risk assessment is known as STUBER, and it stands for Snoring, Trouble Breathing, Unrefreshed Waking Questionnaire. And it was brought on by Tate, same guy who did the prevalent studies in the 90s. And it's a pretty simple questionnaire. Does your child snore more than loudly half the time? Are they waking up at night because they're having trouble breathing? Do you notice in the morning that they're feeling unrefreshed? And it's simply scored 1 through 5, which makes it an easy assessment tool. As we'll discuss later, other assessment tools, assign different numerical values for each, so it makes the calculation and range very different. However, this is simple, and it allows for the identification of those at risk for prolonged recovery, oxygen requirement, and the need for escalation of care. Do they need to go to the ICU later? And a score of 3 or higher has a 3-time likelihood of having an incidence of PRAE. The next perioperative tool that we use is the COLDS inventory, and it was given by Lee. And this is a little bit more complex, but interestingly enough, the study was published for elective surgeries, specifically for tonsillectomies. But it has moderate predictive ability, positive predictive value, and it's used more in conjunction for clinical decision making rather than risk identification. And a couple of the reasons why is, as you can see on this chart, is that the sensitivity varies as the score gets higher. And the specificity doesn't necessarily increase and correlate that much either. But what they did notice is that the score was 19 out of 25. It indicated a significant risk of prey, and they recommended that postponing surgery would be beneficial for the patient. Along those same lines, what are some of the risk factors that go into the decision making outside of these stratification tools? Is there specific things that we can look for in a particular patient population with these symptoms that we can adjust our management for? And the answer is yes. And a lot of this data comes from the apricot, which is a pretty compiled guideline. And they notice a slew of different things. But interestingly enough, I wanted to highlight a few of them because they're pretty specific in pediatric anesthesia as compared to the adult population. So, age, younger children had a tendency for collapsed airways, they have lower oxygen reserve, and they have a higher O2 consumption, especially during times of stress. And while you're thinking, yes, Diana, this makes intuitive sense, the other thing to consider is that the cutoff for this age is 3 years. Operations clearly happen on children after they're 3, but the incidence for prey decreases by 11% every year that they're aging. The other thing that's interesting with age is that the most common age for a child to undergo ear tubes for ENT surgery, which are generally these kids that are coming with cough, runny nose, and having those upper airway concerns, are in this age range of cutoff at 3. And so it's really interesting that risk decreases by such a large amount, 11%, with every year that they age, with the most concerning risk being those that are under the age of 1. The other thing, interesting enough, is prematurity. And this is prematurity less than 37 weeks gestation have a higher risk of apnea. And the reason for that is because they have immature respiratory brain centers. They haven't had enough time in the real world yet to develop all that. And they have impaired gas exchange and bronchopulmonary dysplasia. This prematurity pretty much sets their airway at risk for hyperreactivity to anesthetic, not only during this window that we're looking at, but a large amount of the data suggests that it is long-term as well. And the incidence of prey in these population as well is 2 times compared to a term infant. And the other one I wanted to highlight over here in this chart is morbid obesity. It has an odds ratio of being 3 times more likely to have prey incidences when compared to non-obese children. Obesity is an interesting factor because it not only has an independent risk for increasing perioperative airway concerns, but obesity also increases the risk for a patient to have asthma, which is also on this list, and obstructive sleep apnea, which is embedded in the snoring aspect as well. So obesity, as a growing concern in American society, this is something that I think further research will be targeted at in the later years, especially for this pediatric anesthesia population. But my question to the audience, and something I really wanted to think about for me, is how modifiable are these risks? You know, a 3-year-old doesn't know that they're going in for elective surgery or emergent surgery at 3. You know, we can't fast forward a time button to say, hey, I really want to decrease this risk. Can we, advance in age a little bit? The other thing we can't adjust for is prematurity. So a lot of these risk factors are something that we can't necessarily change, but I wanted to highlight that because that'll come back in later. So let's get to a game plan. Every anesthetic has a game plan, and they also have game plans part B if you've ever met an anesthesiologist, because they usually are pretty prepared when it comes to the operating room. But the first question is, do we actually need to delay the surgery? Usually, surgeons will agree that if there's been a fever within the past 24 hours with any of the risk factors that we talked about before, usually they delay about 2 weeks. If for some reason the patient was admitted to the hospital and underwent a respiratory viral panel, and any part of that panel was positive outside of RSV, flu, and COVID, they usually delay 2 to 4 weeks. And then specifically for RSV, flu, and COVID, they delay 4 to 6 weeks. And the reason that this increases for RSV and flu is because these children are usually the most ill. This is what they consider the bad version of respiratory hyperactive airway concerns, and they usually present more ill. So they'll be less active, they'll be coughing, sneezing more, generally more symptomatic, and therefore they want to delay until this time period to where they're usually no longer as symptomatic. So in terms of pre-medication, is there something that we can do in our anesthetic plan to, prevent these respiratory concerns? And actually, the answer is yes. I wanted to specifically highlight this 2019 REACT trial. It wanted to assess whether or not inhaled albuterol treatments decrease the risk of PRAE. It seems rather intuitive, but it's something that we didn't really research until 2019, even though these discussions were starting in the 1990s. Excuse me. And interestingly enough, yes, when we administered the albuterol treatment, they were found to be 2.8 times less likely to have PRAE when they were pre-medicated with albuterol. And the other interesting note is that usually midazolam, the benzo, is usually held for analytic purposes because it increases the reactivity of the airway. Moving on to intraoperatively, do we see something different in our anesthetic plan intraoperatively? And the answer to that is yes as well. So IV induction appears to reduce PRAE in existing airway inflammation. And what we mean by that is a child that we know that has asthma, a pretty reactive airway at their baseline, we usually try to go for an IV induction. And so, but what are the practical limitations with that? Kids don't necessarily like IVs, is this an emergent case where we definitely need an IV? I think that's one of the big things that I wanted us to discuss and to consider, because IV induction is something pretty common in adult medicine, but not necessarily so much in the pediatric world. Another study looked at the airway choice. This is pretty clinician dependent whether or not they want to risk versus benefit. Do they want a supraglottic airway device, also known as an LMA, which sits above the the larynx, and does that have a better airway to secretion ratio because it sits higher? Do they have less secretions over the fact that the airway is less secure in terms of intubation purposes, and that gives a risk? So it depends on how the anesthesiologist wants to play their cards. Do they prefer to have a more stable airway? Do they prevent the secretions and prevent the airway? But the interesting thing I really wanted to highlight is this incidence of maintenance. So we talked about a little bit earlier about how IV and all that is pretty common in adult medicine, but the 2010 Lancet article showed that there was an increased incidence of PRAE with inhaled sevoflurane compared to propofol. But yet propofol is not widely used for these patients. And it's interesting as to why. It's gaining popularity, but it's not necessarily widely studied in pediatrics. And I think this is a field of avenue and further research in the field. But in addition, they noticed that sevoflurane, which is usually the most common pediatric inhaled gas, is better for less reactivity than desflurane. It makes sense. Desflurane is usually a more irritant. It's more pungent. It's more gross, as kids call it, than sevoflurane. So it's usually less used. But interestingly enough as well, isoflurane has bronchodilator effects in addition to the anesthetic. So it's shown to decrease bronchospasm. Moving on to postoperative. So there's a lot of talk about when is it best to extubate if we have intubated. Some anesthesiologists in particular institutions prefer to do a deep extubation versus an awake extubation. To be honest, a lot of the verdict is still out on this because different clinicians do it different ways. Some clinicians prefer to have deep extubation because they allow for more manipulation of the airway. It's easier, but some just prefer to do it awake. And then a lot of the postoperative management is comorbidity driven. So does this patient have obstructive sleep apnea so that we know that they might need non-invasive ventilation? Or do we have access to high flow nasal cannula? It's all kind of depending on what their baseline of hyperreactivity was based on their symptomology, and knowing that they still can be transferred to the ICU for slower means of ventilation, weaning off the ventilation. Ideally, we don't want a kid to stay on ventilation, but sometimes that does happen. And the pediatric anesthesiologists that I know usually counsel their patients very well on if that might be a concern. And then the other thing I think that's important to talk about is what are the resources in the PACU and are they educated? On the other slide, I didn't necessarily highlight it, but there was a risk stratification for mixed versus non-mixed care teams. And they really found that mixed care teams were more educated and able to help in an instance of need in these post-operative settings. So moving forward, how can we use this COVID respiratory viral testing? You know, can we use it on everyone? Is it, cost effective? What are the benefits? And to be honest, there's not really much benefit for preoperative RVP testing, predominantly because it's high cost and a lot of the history taking and the clinical physical exam offers more benefit than just the testing and risk stratification. However, the one thing that is usually tested is if a patient has been delayed for surgery and they need to reschedule. Usually they will test for RSV and flu, and because they are known to lead to increased hospital stays and unplanned ICU admits as well. The other interesting note is that there's a little bit of preliminary data from Texas that's showing how mild symptomatic upper respiratory infections, notably rhinovirus and enterovirus, may also have an increased risk of prey, which is interesting because in the past, we've always assumed that it was these big bad bugs, RSV, COVID, and flu, that were really the heavy hitters for creating these incidences. And the data might suggest otherwise, which is, I think, a new interesting development. So what I want to talk to you about now is laryngospasm. I kind of went over everything and I ended it with, well, we don't really do much testing, so how can we adjust in the time frame? If something is happening in the operating room, can we fix it? Not just manage more for it before? And the answer is yes. Laryngospasm is the most common um, respiratory event, and it's also the one that leads to the cardiac arrest, like we talked about before. And there are certain maneuvers that you can do that stop the laryngospasm. And honestly, there is an algorithm here that is a little bit elevated above me, but I just wanted to include it here because there is algorithms particularly for laryngospasm, because within the prey, laryngospasm is actually the most studied out of that. So in summary, I thank you for being here and buckling up for this ride. We went over how upper respiratory infections in prey are important. We went through the history and the clinical practices as well. Here are my references. And I just want to send a special plug here and say thank you to the Society for Pediatric Anesthesia. I have set a couple links here, but I wanted to highlight this subcommittee for pediatric anesthesia education for residents and students. Joining the Society for Pediatric and Anesthesia is free for students and residents. It's a great learning tool, and they also send out a new article of the day, which is where a lot of this journal club entry was rooted in. And with that, I'll take any questions that you might have.